Morning, everyone. Thank you to Kathleen, our incredible staff, everybody that took part in making today possible. Let me adjust this thing real quick. You know what? I'm going to just take it out of here if that's okay. Our first speaker, everyone should be pretty familiar with. Dr. Florian Eichler will be speaking about new technologies and old trauma. So give it up for Florian.
So a lot of you are going to be speaking today. It's important that you be up close to the mic so we don't get feedback, and I'll help you with that.
Great. I can't believe it's been 10 years. Let me just say what an amazing job Kathleen and Kelly have done over the years to drive all this forward. And I think far from it that without the scientists and clinicians, you'd be sitting here just drinking coffee. The building community together by being together and exchanging and motivating all the things we're doing as clinician researchers is tantamount and key. So I chose this title to acknowledge some of the excitement in the field and the things that are happening with new technologies, but also to acknowledge that there is still a huge unmet need in the field, and how I think of this and how I hope this motivates all of us to move forward and make progress. Just briefly here, my disclosures. I know many of you are new to this community as well, and I thought I would just lay the land by introducing briefly what seems on the surface to be a simple problem, which is a single gene disorder, the single gene being ABCD1 encoding a peroxisomal half transporter that sits here inside a part of the cell called the peroxisome and transports very long chain fatty acids into that peroxisome. So a single gene disorder where you have defects in this gene that should be easily correctable, should be something that can be tackled, and should have a relatively simple solution. As we go through this today, you will see that far from it, there is complexity here. There's a metabolic defect. There's accumulation of very long chain fatty acids first that result from this gene defect, as those lipids cannot traverse into the peroxisome for degradation. And then it gets even more complicated. We have various different organs that are affected, everything from the adrenal gland to the nervous system. And within the nervous system, we actually have various different phenotypes that were recently nicely summarized by Mark Engel and the Amsterdam group in an international consensus paper, acknowledging that from this single gene disorder, we actually have a host of various different manifestations, ranging from an inflammatory brain disease to spinal cord disease to adrenal insufficiency, and more recently also in women, a disease and manifestations that for many decades had not been acknowledged, but we now recognize as being an important part of this disorder, knowing that more than half of women develop symptoms over time. So I hope I've just given you a quick overview of a single gene disorder with various different manifestations and a path in between that we need to understand. We call this in medical terms pathophysiology. How do you go from a single gene defect to lipid problem to the ways in which the cells are harmed to organ dysfunction and our daily lives being impacted. So where are we now? I think we're all very excited that there is approved therapy by FDA as of last fall. I think a real hallmark and a real milestone in our field. It was the first approved gene therapy for leukodystrophy. However, it only really addresses a small segment of the population, and there's no commercialization outside the US, which is still a huge problem and something we have to acknowledge in terms of access and in terms of equity of patients. New trials, however, are underway. We have gene therapy trial for AMN, small molecule therapy now for adult cerebral ALD. I should acknowledge that a huge worldwide trial for AMN was also conducted with a small molecule. And we have first symptomatic therapy for women and trials, newborn screening in the US, Netherlands. We have wonderful collaborators from overseas who've been really driving and being leaders in this field. But with that also comes new challenges that you will be hearing about from Stefan Kemp, variants of unknown significance, that I think all the complexity being stated warrants one thing, namely collaboration. We need to all sort of put together our heads to understand how the clinical data fits with the mutation data and lipid abnormalities. A large population of ALD is still without treatment. So while we have had some success, there's still so much more ahead of us. Here's how I see the current trial and treatment landscape for ALD. You have everything from adrenal insufficiency, cerebral ALD, having either reached standard of care or now being approved by the FDA. There are various other trials that also started as AMN trials, now luckily coming to the cerebral ALD field. And I also want to acknowledge that we have at least first symptomatic studies and trials for women with ALD. It's not much, but it's a start, and we need to push much harder and further. So having stated the pathophysiology, this is how I think about targets for new technology in ALD. And I will say at our board meeting, the one thing we all, as directors of the board, acknowledge the most important thing to us was new investigators and new research. And I hope that each young investigator who's here in this room thinks about various different targets in this disease and makes at least one of these targets their own, to acknowledge that there is really a lot of ways in which we can impact ALD, whether it's starting with a DNA gene defect with gene therapy. We still have to embark on antisense oligonucleotide studies that will address the RNA level. We've had for years thought about lipid modulation, and I think that still is an important, valid target, how to achieve substrate reduction or achieve alteration of lipids. Small molecules have an important role in altering cell metabolism and impacting cell health. Cell transplantation has for decades been the one way in which we can alter and impact the most progressive inflammatory form of the disease. And immune modulation is still something we continue to think about. So I will focus briefly on the targeted therapies and just give you an introduction to in vivo gene therapy versus ex vivo gene therapy, because it can be confusing when you hear about gene therapy and you think, is this all one thing? Actually, it is not. There are different approaches to gene therapy. In brief, the direct delivery, where we inject a viral vector carrying a healthy copy of a transgene directly into the body, to an organ we call in vivo gene therapy. Often this is AAV mediated. This is different from ex vivo gene therapy, where we harvest cells from the body, transfect them with a lentiviral vector, and deliver those cells back after a brief amount of immune modulation. You'll hear about both of these modalities today later. So just to, in a whirlwind, provide the rationale for ex vivo gene therapy in cerebral ALD. So here we have for many years known that a bone marrow transplantation with a well-matched donor performed in the early stages of disease dramatically improves survival And this is for decades been really the only modality we've had that has been able to rescue these kids at risk of decline and death. And we think this is because there is a rim of microglial cell death that surrounds the progressing inflammatory demyelinating lesion. And if you bring in bone marrow derived monocytes from the donor, they enter into the CNS, differentiate into microglial-like cells expressing normal ALD protein. So this ex vivo gene therapy, this bone marrow transplantation modality inspired the ex vivo gene therapy approach for childhood cerebral ALD, acknowledging that there was here a problem with finding allogeneic donors and finding donors who were good matches for children, many children suffering from engraftment problems and graft versus host disease. So this is work that was started decades ago by Patrick Albourg, Nathalie Cartier, and then Christy Duncan and David Williams really were the leaders in helping us move this program forward. Here again, boys who have inflammatory brain disease, their bone marrow cells are harvested, they're transfected ex vivo in a dish with a lentiviral vector carrying a healthy copy of ALD, and they're then returned back to the boys after a brief bout of immune modulation with either busulfan cyclophosphamide or busulfan fludarabine. This is, as I mentioned before, led to the first FDA approval for gene therapy. So since that approval, we have had long-term efficacy and safety of ex vivo gene therapy analysis of 67 patients with cerebral ALD across 2 different trials. And this is now commercially available. Most patients, 94%, achieve stable neurologic function without major functional disabilities. However, we also have to acknowledge there have been setbacks, and we have recognized that there's been myelodysplastic syndrome arising in 5 boys so far among these 67. So you'll hear also about this later on today. A different gene therapy approach is the in vivo gene therapy approach, which really aims to target not the brain, but the spinal cord, and how to target the late onset form of ALD that affects the spine. This really comes from work that was inspired by the SMA field. So in spinal muscular atrophy, there's been, as many of you know, two approved therapies, one with an antisense oligonucleotide, one with an AV9 targeting a structure in the spinal cord. And so we decided that we were going to package ABCD1 into an AV9 and see if we could do similar to the corticospinal tract and dorsal columns that run up and down the spinal cord. And just to cut a long story short, this is able to target peroxisomes in not only in the dish in vitro and correct very long chain fatty acids, but also be delivered into brain either by IV or ICV approach, so into the ventricles, and correct very long chain fatty acids, suggesting that this is becoming functional protein. And this work was then extended by Yi Gong to lead to an intrathecal osmotic pump approach that in a dose-dependent way was able to deliver to the spinal cord across different segments, and is now being translated into a human clinical trial that started at UMass. I'm very excited that Larry Hayward is here today, who will speak later about this work. And I should also acknowledge that the site in Amsterdam just opened and will be also enrolling first patients. So 2 different forms of gene therapy, one for the brain, ex vivo gene therapy, one for the spinal cord, in vivo gene therapy. Different approaches, meaning to target different parts of the nervous system and different cell types. I will say the field of antisense oligonucleotides has really taken the field of neurology by storm, but not yet seen trials in the field of ALD. What are antisense oligonucleotides? These are chemically modified single-stranded DNA molecules. They are really composed as sequences complementary to specific RNA. So they don't really work on a DNA level, they work on RNA level. And they can help in various different ways. They can help degrade RNA. They can help with read-through of RNA. And so there have been various disorders outside the nervous system, inside the nervous system, such as spinal muscular atrophy and some neuropathies that have benefited from this. So I think we're going to see in the coming years more modalities using ASOs. I will acknowledge that there's first work emerging out of Kennedy Krieger, thinking about how to compensate for ABCD1 function with the closest homologue, meaning ABCD1, ABCD2, that can also compensate here for ABCD1 and is expressed in different cell types than ABCD1, but has huge potential to perform lipid correction and restore health in the cells that are ABCD1 deficient. I also think that new strategies to restore ABCD1 function will in future rely on ASOs. So I'm deliberately here telling you a little bit about the things that I think are going to happen in the future. While they haven't happened yet, I think there's really good justification and rationale to perform reactivation of the inactivated X chromosome. So as most of you know, women have 2 X's, men have 1 X. Men cannot compensate by using their other X, but women could, as work by Jenny Lee and others who have been working in the Rett syndrome field have shown for many years, by targeting a certain structure on the X chromosome called XIST with compounds that disrupt RNA structure, you can overcome that inactivation. So there's some active work happening at MGH on this. Just to also acknowledge that beyond ABCD1, there are many other genes and proteins and enzymes that play a role in lipid metabolism. And I should acknowledge that there is SCD1 that is responsible for desaturation of saturated very long chain fatty acids. And there's also an enzyme called ELOVL1 that performs the chain elongation to the very long chain fatty acids. Keep in mind that these red lipids here, and you'll hear more about this from Stefan Kemp later, are the specific lipids that we consider toxic in adrenoleukodystrophy. So just to highlight here, work by Josh Bunkowski and Stefan Kemp that were looking at metabolic rerouting via SCD1 induction to impact ALD. This has great potential from zebrafish to fibroblasts, human fibroblast cultures, where screening can be performed to find small molecules that could increase SCD1 expression and overcome these toxic saturated very long chain fatty acids. I think for many years, Stefan Kemp has educated us about the role of ELOVL1 and the elongation of these very long chain fatty acids. And I hope here again, there is more opportunity to go beyond the compounds that have been used in the past. So I want to pause here briefly after having talked about many of the new technologies. And I hope you're excited about the fact that we do have an opportunity here to use these new technologies to the benefit of these devastating diseases that affect us. I also, at the same time, while speaking about the excitement of new things, also want to acknowledge that we all experience trauma, and all of us have, in some shape or form, experienced loss. And I think working in the field of biomedicine, all my coordinators can attest to the fact that one of the first questions I ask them when they get hired is, who of you have experienced, what loss, and do you know anybody close to you who you've lost? I don't do this in order to probe, but more to recognize that the experience of trauma is a universal experience. It's a human experience that all of us go through. And if we can acknowledge that and find that place of pain, we can help transform that and use that in order to motivate us for change. And for my part, I think one of the reasons I stepped into a very difficult field of brain disease is and loss is because I lost my brother when he was 5 years old. When I was 5 years old, and he did not die of a genetic disease, but he died after falling out of a train. And I think one of the things I learned from Hugo Moser and others was that it's not only about thinking about the science, but also about acknowledging personal relationships and finding ways to move forward together. And so Hugo Moser was a brilliant metabolic biochemical specialist, but he also taught me that it was about finding out how to work with patients and recognize that patients are not really different from us. And so I think I found great inspiration there. And it was really experiencing boys with cerebral ALD, as shown here on the far right, that died of cerebral ALD on my watch, that really made me think, you know, this is something where we can find a path through despair to hope and motivate ourselves to move forward. So I just want to acknowledge that while we have been able to address a small segment of this population that has early cerebral ALD, namely here, everything up to a less score of 9, it is much harder to get to the boys who have a less score above 9 and 10 as they start to succumb to cortical blindness, loss of communication, tube feeding, wheelchair dependence, and the like. But I think every time I see one of these boys, as seen here, who are struggling with basic function, such as visual processing and being at an advanced less score of 13, there is a sense of knowing that you're between a rock and a hard place. This is not a boy who we could transplant easily, and we don't have good options in order to impact activities of daily living for these children. This is not only about visual processing, it's also about gait problems, ataxia, fall risk. This is a boy with a less score of 18 who has an NFS of 7. And walking difficulties and balance problems continue to pose fall risks. So how do we get to really think about these boys with advanced cerebral ALD who often live for decades with needs not well studied? And here's just our cohort that often we don't publish or talk about because it's not a success story, but I think each one of us who sees boys with cerebral ALD with advanced stages, we acknowledge that there are few options here. Many of these boys live for decades in bedridden and often transplanted, do not do much better than those that go without a transplant. And we don't really know how to optimize care for these children. And we have really, in my mind, not done enough. I think there's a real opportunity here to improve our understanding of function. Men with advanced cerebral ALD, they often decline very quickly as well. I think for many years we've said this is the adult disease is AMN, but with now the recognition that here cerebral ALD can also set in, psychiatric issues, poor self-esteem, concurrent myelopathy, and comorbidities make it particularly difficult for transplantations. And I will say I'm very excited that we are now having first trials in this field using a small molecule approach with lariglitazone. So there's, I think, a path that we need to continue to follow and see if we can find new targets and new ways to impact this population. I think on the positive side, there's input from affected families who live with this day to day, who know that improving communication, pain, spasticity management is meaningful to these patients. We need to understand adaptations and equipment, improving education for local providers, these are low-hanging fruit that we can do now. We can look into seizure prevention during transplantation, guardianship questions. We are working on understanding vision and visual engagement, as we think that's important and meaningful to these boys at this stage. So this is a pathology that is progressive, that extends beyond the microglial cell loss to include the vessels that are being affected by inflammatory cells and spreads out into the white matter of the brain. And I just want to acknowledge that here again, targets of the blood-brain barrier and are key, as well as discovering new AAV capsids that can target critical cell types such as microglia. So Patricia Mussolinos for many years been studying how these endothelial cells that usually keep the blood-brain barrier tight break up over time due to the gene defect, and also how Casey McGuire has now been finding new microglia, new AAVs that can target microglia. For many years, this has been thought to be unattainable, but now we're finding not just in mouse cells and non-human primates, but also using new organoids, ways to target microglia, which raises the hope that we could deliver very quickly new gene therapy at a critical stage of disease. So all stages of ALD deserve attention, and I think we want to acknowledge that the burden of disease in AMN is still largely unaddressed. I think we've been thinking about this as a corticospinal tract disease as well as a dorsal column disease, but I think more recently I've been interested in what controls the function of upper motor neuron pathways, and thinking about how and we can also learn from the Parkinson's field around dopaminergic and cholinergic systems. And why is that? Well, it turns out that ABCD1, that first gene I told you about early on, is highly expressed in certain parts of the brain, namely in the basal forebrain, in certain parts where these cholinergic neurons have a lot of ABCD1. And this was first discovered by the group in Vienna, by Johannes Berger and Höfberger. And we have now also found this in the in mouse wild-type mice, that you can detect high levels of ABCD1 in the basal forebrain, hypothalamus. And when we deliver AAV9 stereotactically into the ventricles, and we can identify a lot of ABCD1 going directly to these basal forebrain neurons. And we think this is the reason why when we deliver not just at 6 months, but also at 12 months into the ventricles, we're seeing resolution of hind limb clasping, which is the normal motor phenotype that we see reliably in this ABCD1 knockout mouse model. Telling us that really it's not just about the dorsal columns and the corticospinal tract, but about the whole cortical control of motor movements, something that has long been known to the Parkinson's field. But I think that we in the field of ALD are just starting to wrap our heads around. There is a reason why ABCD1 is highly expressed in certain parts of the brain, even though the pathology may immediately not be jumping to the fore. I think in women, it's for several years, for those of us who've been seeing women, being clear to us that there are movement disorders that are emerging that are of a higher preponderance as in the normal population: tremors, dystonia, speech abnormalities. The very first mothers of boys with cerebral ALD had presented at our institution back in the 70s and 80s with torticollis, a tilting of the head and neck, and only now are we starting to document that and understand that as a separate important phenomena. Burden of disease also encompasses the smallest, most peripheral nerve fibers, and you can see that here lots of women in particular have swelling of the feet, redness, pain that affects them day to day. A lot of these women have fractures, have injuries, and it exacerbates this small fiber neuropathy. just to acknowledge here that these very small fibers in the skin, they originate and go all the way back into the dorsal root ganglia. And these dorsal root ganglia, understanding the role of ABCD1 here is tantamount. We are excited that with AAV9 we can target these dorsal root ganglia, but understanding the underlying function here is key. So with that in mind, we spent some time looking at dorsal root ganglia and where ABCD1 and peroxisomes are expressed. And you find actually peroxisomes mostly in satellite glial cells that are supporting the neurons in the dorsal root ganglia. And we think that this is an important function that goes awry and leads not only to accumulation of very long chain fatty acids, but we've also found an increase in certain mechanosensitive channels called piezo-2 channels in ABCD1 knockout mice. And if we block those piezo-2, that piezo-2 overexpression, we can improve painful sensation to touch in the mice. So it is early days, but something that we feel could be helpful in understanding the propagation of pain in adults with ALD. So in closing, I just want to acknowledge that newborn screening has really led to an enormous revolution in the field of ALD for the US. But it is really only a beginning. We need to not only identify these children, we need to understand what these variants actually mean, whether they're truly pathogenic or not. And then we need to have robust monitoring programs so that we can over time address the needs. And I think it really motivates a biomarker-based risk prediction that needs to occur together with that monitoring program. And I think a first step in this direction is coming through international collaboration with Europe. Nice paper by Isabel Weinhofer. I know the group in Amsterdam has also done similar work showing that neurofilament light chain, important marker of neuronal health, is elevated in boys with cerebral ALD. And I think if we work together in the future, we might be able to get to a point where we don't need to do every 6 months anesthesia in these boys to perform brain MRIs. We could start monitoring their neurofilament light chain levels, but this is going to take probably 5 to 10 years to get there, but it will only happen if we work together. So in summary, new technologies have allowed for molecular targeting, and I today have discovered it's much easier to talk about molecular targeting than about personal pain. So precision requires an understanding of pathophysiology and target cells. Trauma arises from advanced pathology, but unmet need remains. The point I really want to make here is that we need to match up the technology that is now emerging, the amazing progress in biomedicine, with the right disease understanding and those painful points of pathology and unmet need that seem so hard to tackle. But if we understand the target cells, if we understand the pathophysiology, we can bring together these different phenotypes and disease stages and provide appropriate targeting with this new technology. So I'm personally very excited about where we are, and I hope that all the young investigators are motivated to rush in and start thinking about things that I haven't mentioned here yet. I think the vulnerability that we see in biology, the vulnerability we experience as human beings, calls for innovation, calls for working together, and this informs new approaches. So thanks.
Thank you, Florian. We have some time for a few questions. So if anyone has any questions, just go ahead and raise your hand and we can bring the microphone over to you. It's got to be one.
There are no wrong
There we go.
questions. Only my halfway answers. So.
Yeah. Thank you, Florian, for the really nice presentation. I think we know that women suffer more often from pain than men, or women with a myelopathy more than men. Can you relate what you said about the small fiber neuropathy and the specific cells surrounding the dorsal root ganglia? Do you have a hypothesis on why that may be more impacted in women, or?
Yeah, it's a good question. And I don't think we have good answers on the gender differences yet. I do think there are likely important hormonal differences. We know in other lipid disorders can be similar preponderances, but why there might be gender specificity is not quite clear. I think we also don't really understand what the heterozygous state is really about. Today we'll later hear about mosaicism. I think there's far more that we need to learn about that. And in the end, I think these are really about connectivity issues. So pain is obviously a complicated phenomenon. If your connectivity due to a mosaic state allows for areas where there is an excellent integration and other areas where there isn't, then your whole functional network goes awry, which is often something that is a predisposition for pain. So I don't have one clear answer for you here, but I think coming back to some of the discussions we were having at the board, I think there are many more targets and paths we need to understand here.
Thank you.
Yeah. Sure.
We'll bring them in.
Thank you. Alex Keefe. Oh, Alex Keefe, University of Washington. Thanks so much, Florian.
Okay.
I'm curious if with any of the gene therapies and vectors that you've seen, is there a certain threshold that you believe you need to achieve in terms of getting the vector into the cells that you've seen things become efficacious, or it can't, I'm guessing you're not trying to achieve 100% because that's going to be kind of an impossible goal, but what's the threshold you're trying to get to?
So the short answer is I'm trying to get to the threshold that restores health. Okay, so and why I'm putting that out, answering with the principle rather than a number is because disease and life is dynamic. Depending on when you're going in, your cell state and your viability will be quite different in early cerebral compared to advanced cerebral. For early stage cerebral, we came in with new ex vivo gene therapy and we were able to fix that problem with probably a very low % of cells. That will not be the same for advanced cerebral ALD. I think the women, once we start learning how to reactivate the inactivated X, will teach us a lot about what the actual endogenous level of health that is needed. But in short, I think we need to acknowledge that not one size fits all. The different stages. We are not coming into this disease at conception. We're also, coming in hopefully at a stage where there's still some cell viability and pathology is not, the horse is not out of the barn. Patty.
Thank you, Florian, and thank you for connecting us on suffering is a human experience that we can all leverage to be more human. Beyond whatever specifics, I now have a specific question. There is a lot of regulation of every gene in the body, and some of them are microRNAs and other cytokines released by the cells around. So we kind of been focusing on the percentage of gene, like, oh, if you're a woman, you have 50% of your possibility of gene, and you talked about inactivation as a mechanism to skew that. What about microRNAs? The field has evolved, and we know there is an age influence. We know there is a sex influence on how these things regulate genes. I'm dealing with a disease specifically where a single microRNA goes up with age, and that's how our adult patients start to get a very different disease. I wonder, where are we at in ALD with studying some of the, not just how much of the gene itself, allele transcription, but what is it governing that transcription, like that expression?
No, thanks, Patty, and thanks for raising this, which I think is really the next generation of thinking around genetic therapies, which is regulation. And I think right now we're sort of still in our infancy. Clearly thinking about just putting the gene back is too simplistic, right? We're not coming in at a stage where, adaptation hasn't occurred or dysfunction due to an impact upon regulatory environment has not occurred. I was just actually reviewing a paper the other day in Krabbe disease, where people are finding that this most common deletion in Krabbe, GAL-C, encompasses a very important enhancer element that is impacting the entire environment of the genetic landscape. So I think we need to think much more deeply about that. And there's much more there. I think the group at KKI is leading the way in terms of thinking about microRNAs and biomarkers. So this will have to go hand in hand with really solid biomarker work.
After these other questions, I feel like mine is just simple. When you're talking about reactivating the ABCD1 in women, and I'm asking for my daughter, are they going to have to present symptomatic, or are you going to be able to look at, say, father was AMN and go ahead and reactivate that ABCD1 maybe before their symptoms?
Yeah, good question. In general, providing correction earlier before symptoms arise is always better. The problem is it's very hard to conduct a trial to prove that your therapy is doing something unless you understand that there are already symptoms underway. So usually I think the way this works is through a life cycle of different trials. You start first with symptomatic patients, then over time you get more and more to the pre-symptomatic or patients. I think the reason we think this is an important mechanism is, despite various studies over the years not finding clear correlation of skewing of inactivation correlating with symptoms, is because we find individuals who seem to have complete skewing in one direction or another, and they're either completely healthy or they have even cerebral disease in women. And so this is something that does occur. Is it the only mechanism? No, but I think it's an important mechanism in women.
All right. Thank you, Florian.